In Equity Lens, we have heard about health equity and economics, equity lens in patient and public involvement, equity and systematic reviews and secondary data analysis. But where does it all lead to and come from? Is the language we use clear enough to guide our practice, or do we need different terms and concepts? Today's podcast will be around the language used to describe health equity, and today I'll be talking with Naoimh. So if you'd like to introduce yourself, Naoimh.
Hey Rod, thanks for having me today. So I'm Naoimh McMahon and I am a researcher at Lancaster University.
Can you just say a little bit more about your role in Lancaster University?
So I have previously worked at the University of Central Lancashire, worked in the stroke research team there, and that's how I got involved with the Clark originally and then the Applied Research Collaboration. So I've always been working in research, initially doing rehab research around stroke as a physio, and then moving into public health stuff. So at the minute, my role, I've got some funding from the Wellcome Trust to do my own 3-year study looking at the stories we tell around both health inequalities, but also inequalities across different sectors.
Okay, interesting. As regards the type of language used in health equity and health inequality, what do you see are the issues?
Yeah, so this is one of the main parts of my research, actually. And I think there's a number of things that I find a little bit concerning with aspects of the health equity agenda or the language that we use in this agenda. So one of the things is how the terms like health inequities and health inequalities, they actually don't refer to a single problem, but they're more of an umbrella term that includes all different kinds of inequalities. So for example, people, when they talk about health inequalities, they might be talking about inequalities in healthcare access or inequalities in behaviours or the wider social determinants. But also they might be talking about these big picture inequalities that we have. So those headline stats around inequalities in life expectancy or disability-free life expectancy and what it would take to bring about some shift in those graphs that we see. So that's one of the challenges. I think because they refer to so many different problems, it can seem that when people are using the language, they're using it in an abstract way. So we're not actually sure what are they talking about and what is it that they want to change. And I know when we started in the Clark originally, so many years ago, we were all definitely on the same page in wanting to reduce health inequalities. But in our conversations, it was clear that often we were thinking about very different kinds of problems and very different solutions to get to the end goal. So I think that's one of the challenges.
Yep.
The other one that I'm quite interested in is around the language and the labels we use to describe the causes of health inequalities. So I think when we want to try and fix any problem, that's where people generally start. Researchers, practitioners, policymakers, they want to know what's causing it.
Yeah.
But when it comes to health inequalities, I think we can become a bit unstuck about where the causes are and where we target our efforts. So we've spoken about this before, where people make a distinction between these upstream or downstream causes of inequalities, or people might talk about behavioural or structural risk factors. And actually, I think that language can be really unhelpful. One, because again, they can be quite vague. So what you think about as an upstream intervention might be very different to how I'm thinking about it. But also my worry with this focus on causes and risk factors is that can actually really distract us from where these risk factors come from in the first place. So if I think about an example like housing, we see people talk about the conditions or the link between housing conditions and health, but we don't hear people being as vocal about why are these really poor housing conditions in our communities and why are they allowed to persist. So they're just some of the challenges that I'm trying to work through in my research at the minute.
I live in Southport, and the age expectancy of people who live in Ainsdale, which is 10 miles away, is 10 years more at least.
Wow.
It's simply because it's a more affluent area. So that is really interesting. Why are there so many terms in health equity, health inequalities, health inequities, when it might make common sense to actually use the same terms or try to use the same terms so we know we're talking on the same page?
Yeah, that's a really good question. There are so many terms, and to me, they do broadly refer to the same thing, which is if you look across social groups, and it doesn't matter what way you divvy them up, if you look at geographical areas or socioeconomic indicators, gender, ethnicity, there's going to be differences in health outcomes that don't just reflect individual behaviour and choice, but are more driven by social and economic factors. So to me, they mean the same thing. And I think in terms of, I know you've touched on a previous podcast, the inequalities and inequities, we have a better sense of where that's come from because people felt that the term inequalities didn't really capture the scale of the injustice. And so there's this preference for inequities, but certainly in the UK, I think they're used interchangeably. But disparities is another one that we are seeing quite a bit, and it's in the title for the new Office for Health Promotion and Disparities, or Health Improvement and Disparities.
Whichever.
Yeah, and I think one thing that's interesting there is that possibly people think that that might be a deliberate toning down of the language around unfairness, is to focus on difference. And what I actually had a look at the website, and they described the department's focus as being on breaking the link between background and health. So I wondered if, thinking about the difference in these terms, when I think about people working around health inequalities, I think they want to see a fundamental change in underlying social inequality itself, as opposed to just relying on interventions and services to, offset the harmful effects of inequality. So I don't know, I'm just thinking out loud about what the differences might be, but I think certainly there's a perception that disparities isn't as hard-hitting as inequalities and inequities. But as we're going to talk about in different ways, there's a lot of terms and a lot of language in this field that isn't always super clear what their purpose is.
Yeah. As a newly elected councillor, do you see that as an opportunity for you to see how things work in the real world or implement and improve services in the real world?
Yeah, that's a good question. I think, just actually on what I was speaking about, this issue of where do these risk vectors come from, for example, where do these issues around housing conditions come from? What my council role has allowed me to do is just understand why things are the way they are and what power different groups realistically have to make changes for better or worse. So certainly one of my motivations for getting involved with local government is it's very easy for me in a university setting to just keep putting out into the academic sphere these ideas about how we need radical and ambitious action to tackle the root causes of health inequalities. But the reality is that I think most people in local government or the NHS or different organisations, they know what needs to be done, but the laws that we have, our institutions, and some of the ideas that underpin, how society is organised, how our economy is organised, they're just not working in our favour at the minute. So that's what the council role is doing for me at the minute. It's a bit of a reality check, but hopefully, having a better understanding of how our institutions work and how our laws work will help me see, where we can realistically make changes. So I'm trying to be optimistic, yes.
So would that impact on the services you choose to commission, or is that something you're not involved with, or you do?
Yeah, interesting. So at the minute I am a backbencher, which I didn't really know what that was before I came on council, but I understand it now. Some people who are a lot more actively involved in making the decisions, right. And the rest of us contribute our 2 cents where possible. But yeah, there's a lot that I'm still figuring out in that role, and because I'm not directly involved in making those kinds of decisions, I probably still don't have a good sense of how equity features and how much health actually plays a role in deciding who you commission and where you spend the money.
Does health equity need to become more focused and organised?
Yeah. I mean, I think it's back to what I was just talking about. And again, I think we've chatted about this before, Rod, that when we think about being organised, part of it is understanding how things work and what needs to change. And so what I've been thinking a lot about is how we can all be a bit more politically literate in that sense. And certainly I wasn't before I started looking at health inequalities research. So the thing that has been helpful for me to maybe think about is there's small p politics. And if we want to influence, what decisions are made, what services are commissioned, where we spend our money, we can't avoid being involved in that kind of organising and influencing. But I was just thinking today that maybe we don't need to be making health inequalities a party political issue in our workplaces or our community groups, because maybe that's not what's going to work for us. So it's a good question about the type of organising that we do. But ultimately, I think for me personally, having come to health inequalities from a clinical background, I didn't have a good sense of how institutions work, who has influence, who makes decisions. And we seem to constantly see health harming practices happen or they're even given permission to happen by national or local government. So understanding why that's the case and who's at fault would really help us, I think, convey to the public what we're trying to do to maintain public health and just protect people from some ill-willed.
Yeah, I mean, I worked briefly in the NHS for a while, and I was really quite staggered at the way the organisation, well, that's another issue anyway, but it was an issue in the NHS trying to deliver services to people, but service designers didn't know what was actually really needed. But that's a massive issue. And one final question is, it's a dead simple one. What's your vision for the future of health equity?
Yeah, I mean, it's tricky times at the minute in terms of any sort of equity agenda. And I think the thing that is, concerning me and what I'm thinking about in my research is that there's a lot of people who've been banging this drum for a very long time. Health inequalities are not a new problem. They're just, a persistent manifestation of inequality. And I think we've maybe been saying the same thing for some time now, but it's not cutting through for some reason. So, I mean, that's not to say we obviously have made massive headway in raising awareness of wider social, political, economic factors, but translating that into action. So I'm interested to see, and I might be barking up the wrong tree, but I think there's something about sharpening up our stories a bit. And I think, putting people back into our stories, not the people who are affected, but maybe the people who are doing harm as well, because, risk factors don't come from nowhere. Houses aren't left to fall into repair of their own accord. So decisions are made, actions either are or aren't taken by, people and companies. We should know their names. We should be able to, really more clearly articulate for the public and policymakers exactly what we think is going wrong here and what could feasibly be changed. And related to that, I think what I'm trying to do is look across sectors, because I think, again, health inequalities are not unique to health. They feature across the board. And I wonder if we could do a better job or tell a more compelling story about how public services, local government, the NHS, we were all picking up the pieces of harm that is being done by wider decisions that are made around in politics and the economy and things, but do it in a way that actually points to the type of change that's needed. So I think, getting our story a little bit sharper, more specific, naming names and doing it together, not just not health on our own, because health, housing, early years, youth justice, these are some of the areas that I'm looking at, and we're all grappling with the same ideas that, we want to go behind the symptoms and the outcomes that we're tasked to deal with, but ultimately the causes for those are beyond our immediate scope of influence. So it's not straightforward, but I've got really great mentors, policy practice partners and public advisors who are helping me think through these ideas. So hopefully we can come up with something for the future.
Well, thank you. Really interesting conversation, and thank you very much.
Yeah, no problem.
Are you clear what your team means by targeting health inequalities or inequities? Do you think we need to shift the language we use to shift our understanding and practice in health equity? Share your comments with us at #ImplementEquity.